Hello everyone. Welcome here. I am Dr. Iza, and today, as you all know, we are conducting a free webinar on navigating MRCOG OSCE essential tip and tricks for Part 3 proficiency. The targeted audience for our webinar is MRCOG Part 3 OSCE candidates, MRCPI OSCE candidates, MRCOG and MRCPI candidates, FCPS candidates, MCPS candidates, Saudi Board OSCE candidates, and Arab Board OSCE candidates. Now, let me introduce you to our very proficient mentor, Dr. Yasmeen Haseeb. Dr. Yasmeen Haseeb is a professor and consultant obstetrician and gynecologist with over 30 years of experience in the field. She has MRCOG from UK, FACOG USA. She's also a certified healthcare professor in medical education by a well-renowned Dundee University of UK. During her MBBS, she was also honored with President Gold Medalist Award for being the best graduate of the university. In addition to her 30 years of clinical and teaching experience, she is currently the MRCPI OSCE Examiner Ireland. Also, she is MRCOG OSCE Course Faculty Examiner at Royal College of Obstetrician and Gynecologist UK. She is also the elected committee member of RCOG UK for Gulf. Dr. Yasmeen Haseeb has an extensive experience as a postgraduate resident training program director for MRCOG, MRCPI, Saudi Board, and Arab Board candidates. Okay, so I've gone through a brief introduction of our very capable mentor. Over to you, Dr. Yasmeen.
Thank you very much, Dr. Iza, for such a warm introduction. And my heartful thank you to all the RoyalDocline team for their continuous support and the effort which they put in the organization of this webinar. I'm feeling honored to be here for this webinar, and I welcome you, each one of you, to this webinar from the core of my heart. And Isa has already given my introduction, but a brief glimpse about me. I have been working in OBGYN for the last 3 decades, and with the passage of the time, I have been actively involved as a resident training program director for different boards, including the MRCOG, MRCPI, Saudi Board, Resident Board, EBOG exams. And I have been actively involved as an examiner as well for the OSCE in Ireland as well as in the UK, and also in many courses which are to be done for the exam preparation. During all these times, I was thinking that what are the causes of the failure of the candidates who are appearing for the exams? And as you all know, our OBGYN is really a challenging but rewarding field. It takes a lot of the time, not only from the candidates, but also from their families, from their children as well. So I would suggest that how to prepare for this exam. And I was thinking to conduct the courses for this, for my aim and objective, as I think the candidates need a smart preparation as well as a targeted preparation to go through this exam. And OSCE is actually the last cornerstone to get this globally recognized qualification, which are a certification which is passing through different difficulties. And then the people have to take it with a lot of the efforts. However, if your efforts are not in the proper way and the proper direction, then all the effort is in vain. My aim is to guide you and to give you the tips and tricks in order to pass this exam in a smart way. What are the targeted areas which you have to go through, and what are the shortcomings? And in this context, we have arranged this webinar. However, there are our other courses which are in the pipeline specifically for the MRCOG, MRCPI Part 2 exam, as a lot of the candidates are requesting me about that. And I have seen that the people don't know actually how and from where to prepare for the exam. So I would encourage everybody who is here to participate in our webinar actively and post on your questions, because at the end of this webinar, we will have a Q&A session where we will answer all of your queries and the questions. So be with us during this webinar. And I think without any delay, I would like to go to my slides. And Isa, kindly give me a hand once everything is working very well.
Okay.
Yeah.
Okay. In the meanwhile, I'm gonna suggest all the participants to please go on the activities session on the bottom right side of your screen. Um, and you can give us your questions in the Q&A section. Okay, so that would help us out a lot, and all questions will be answered at the end of the session. So I would really appreciate your input, your feedback, and any of the queries that you have to put in that section. Thank you so much.
Yes, Isa, can you kindly let me know that can you see my slides?
Yes, I can.
So everything is going very well, I think.
Yes.
So my dear all candidates, all my friends, my peers, let's start with our webinar now, and MRCOG Part 3 OSCE Tips and Tricks. How to prepare for your MRCOG or any board exam. Actually, I just put MRCOG because I'm actively involved in this exam. However, these uh, guidelines are for all the types of the exams which you are preparing. This is a slide, a short introduction and a glimpse for whatever I have done in my life. So you can see that. And so congratulations, first of all, the people who are here and they have passed their MRCOG Part 2 exam, which is really a glitch to get through. And after passing the Part 2 exam, remember you have to relax only for a few days and you have to get back towards your study. Remember, this is important to get this lead time, to utilize it very wisely. Don't waste this time and don't waste for the exam results the people who have just given the exam and they are just either passed or they are just waiting for their exams result as well. This is also the advice for them. First of all, the first thing you need to do, you have to understand the OSCE exam, which is the backbone. Understanding is the backbone. Organize your study modules. Immerse deeply in them. And very important, believe on yourself. You can do it. If I can do it, other people can do it. You can also do it. Wise selection of the OSCE material and wise selection of the OSCE teachers, mentors, and the courses. These all things we will go through this webinar today. So what to explore on the RCOG website? Here you can see there is a link for the RCOG website. You have to go through it very thoroughly. Read each bit of it. Go through the syllabus. Go through the format of the exam. What are the domains? First of all, you need to understand these domains. Then also you have to go through the revision resources. And very important, this is free for everybody. This is by the RCOG that this is free for everyone. Anyone can get through all of these things. So syllabus, format, domains, revision resources. This slide has been taken a screenshot from the RoyalDocline. Actually, what the MRCOG Part 3 OSCE exam is looking in the candidates. Please listen to these words. They are very important, as I have been engaged in lot of the exams as well as the teaching. So you have to understand what exactly they are looking. They are looking in you knowledge, skills, attitude, and competences. Because MRCOG Part 3 exam not only access your clinical knowledge, but clinical skills, your attitude, your communication, not only with the patient, with your colleagues, with the family members in the real clinical scenarios. So remember this. These words, knowledge, skills, attitude, and competences. This is the whole resource, and this is the whole thing which the examiners are looking in you. Passing this final exam will lead to the award of the designatory letter from the MRCOG, of course, and finally, you will be ending up in that area where you will get your membership from the college one day. And I wish you good luck, everybody, to be there for this ceremony soon. So here you can see that the format. The college is saying very clearly that what is the format of this exam. This is also a college slide. The MRCOG Part 3 clinical assessment aims to assess candidates' ability to apply the core clinical skills in the context of the skills, knowledge, attitude, and competences, which are defined in the Part 2 curriculum as well. Then comes to the syllabus. Syllabus is actually the SIPs and the people who are going after passing to the through all the MRCOG parts. Some of the people, they're going to the CSER. This is the equivalency with the CCT training in the UK. So SIP is actually the capabilities in practice. The SIP is capabilities in practice. And the knowledge requirements, they are contained in the MRCOG syllabus curriculum 2019 document. You can all download this syllabus from there, and you can go through that how the UK candidates are trained according to this document, according to this curriculum. If you want to pass through the MRCOG Part 2 and Part 3 specifically, you have to go through this document. This is very important, and you have to understand what are the SIPs. Then comes the revision resources. So resources to help you pass the MRCOG. So we will see each part individually. So very important thing that you have to remember that when the exams are coming, for example, I just took an example for you from the RoyalDocline website, from the RCOG website, that how the November exam will be. You have to know where you want to appear for this. This is exam venues like Cairo, Kolkata, Hong Kong, wherever you want to appear. Then the deadline for the candidates to up their home address and their email addresses. This is the date. Then when you will be going for the assessment of the training deadline, this is the date. And then priority booking window opens. Then the priority booking window closes. These are all the dates which you need to know, and then the results will be released on Wednesday, 11th December 2024. College is very clear about everything, and the people who are going for the Part 3 exam, you have to remember all these important dates. Then let's go to the MRCOG OSCE exam in the real sense. It is clinical knowledge, skills, attitude, competences, and each task is assessed based upon 5 domains. This is actually the exam. When we are there, they always tell us that this is the key, and this is the scenario, this is the actor instructions, and you are going to assess the candidate in these points, in these key areas, and then we have to mark that sheet accordingly. So what will be the format of the task? Format of the task is either the simulated patient or a simulated colleague task. Simulated patient, as you all know, they are usually the actors which are given the instructions. And in the early morning, the instructions are given to the patient and they are told that how they have to behave. For example, if she is in labor, she will be behaving as a lady who is in the labor with all her crying and everything. Or if the husband is the one who is an angry husband, then he will be given the advice accordingly and he knows his all instructions. Similarly, you can face the colleague there, and the colleague can be either a final year student or can be a FY student, FY2 student, your junior colleague, the colleague who is in difficulty, like sort of the different scenarios you can face on over there. They are given the instructions. They involve the candidates to interact with the actor who has been trained and fully briefed in the role and what he or she has to play. So remember, it can be he or it can be she. The actor will know all the relevant details which are pertaining to the case, and they will have some scripted questions to prompt if they are needed. This is about that. I hope so this is clear. The second type will be a structured discussion task. Structured discussion task, which I like very much, is very easy to go through. This is just, an examiner as well as candidate. But the examiner is asking you the questions. He actually want to pass you. He is also giving you the hints. The candidate should be very clever and he should know that what the hint is being given by the examiner. And in the structured discussion task, I always tell in my rounds as well, they are looking for some of the points which are the key points and the key words which they want to listen from your tongue. And you have to go through all these things. The examiner is also having a detailed instruction that how he has to behave, and we are instructed to behave as a mask face. We don't say anything, we just give a prompt for the candidate so that he moves through the task quickly and he does not waste his time and he does not run out of the time. The examiner may give the candidate further information as the scenario evolves, and then he or she may ask a further question. You are the one who can guide the examiner at this point. If you go through this structured discussion on the daily basis with your family, even with your husband, with your wife, or with your family members, or with your colleagues, you can go through it. Just talk. This is an area where you need to talk. Then comes a linked task. This is a third type of the task. It is to allow for more depth in the assessment of the applied clinical knowledge. A circuit may contain a linked task. It is not always the case. Sometimes in the circuit, they put the linked task, and sometimes they don't put the linked task. For example, there was a circuit one time where the question was, there was a swab left in the vagina. And then it was an actor sitting over there asking about all the questions and the scenario. And in the next linked task, there was a point related with the clinical governance, which including the incident reporting, risk assessment, and risk analysis and duty of candor. All of these buzzwords the examiner wanted to listen. And the examiner was sitting over there, and it was a structured viva, this linked task. I think it's clear. It may also be a task where the candidates are required to undertake some writing task. For example, you are required to write about some patient information leaflet. You saw something in the one task that where you were supposed to insert the intrauterine contraceptive device. And in the another linked task, you might be asked to write about or critically appraise the information leaflet about the intrauterine contraceptive device insertion. I hope so. The linked task is clear to the people. Here is the syllabus. These are the syllabus modules. So we have gone through that what are the tasks, and now we will see what are the 14 syllabus modules. And syllabus modules, part 3 syllabus modules, how they go with the OBGYN curriculum modules, you can see all of them. And they are teaching core surgical skills, post-operative care, antenatal care, maternal medicine, management of labor, management of delivery, postpartum problems, that is a puerperium, gynecological problems, that is a general gynae, subfertility, sexual reproductive health, early pregnancy care, gynecological oncology, urogynae, and the pelvic floor problems. These are the modules which you have to go through and learn what is required in each module. Each module has got its own strategies, which you have to learn, which you have to memorize before going to your exam. And you have to practice all of these things and these strategies. So now come across to the format of the assessment, how the assessment is done and what is the format, how we are asked to assess you. Actually, the part 3 clinical assessment consists of 14 tasks in a circuit. There may be a station where there may not be any task. You may also feel that during that exam, you may also see that, or there may be a running 14 stations. It depends upon how the RCOG plans out the exam. Context of the 5 domains are defined by the Journal Medical Council. Please be with me on this slide. This is the nutshell of today's webinar. This is the patient safety. And remember, patient safety and patient safety and patient safety. You can be failed in anything, but if you fail patient safety, you are failed. Straightforward. Patient safety is the main thing, a static point in each and every station, whether it is asked from you or whether it is not asked from you. It can start from the confirmation of the name of the patient, her identity, to allergies, to medications, indications, contraindications, using the sterilization, everything, patient safety and patient safety. Please remember these words. Then communication with the patient and their relatives, communication with the colleagues, information gathering, and applied clinical knowledge. So these are all the domains which you have to go through, and you have to understand what are these domains and what is required in each and every domain. Let's see the patient safety. What is this domain? We are going through the first domain, which is a patient safety. And this is the most important domain, as I told you. What is it? Accurate clinical practice, right patient identification, safeguarding the woman and fetus. Very important. All of these points and all of these words: chaperone, ethics, consent, safe and accurate prescription, excluding the allergies, safe use of the medical devices and instruments, like how you are using the forceps, how you are using the vacuums, what type of the vacuum, what is the station, sterilization was done or not, patient was explained or not, did you assess that whether she is a real candidate for this vacuum extraction or for the forceps. These are all the things which are required about the medical devices and instruments. Use of the guidelines during the treatment of the patient. I have highlighted it. Please be sure that this point is very important, because many a times, your senior colleagues, they are guiding you. Oh, you don't need to read through the guidelines again. There is no need to go through the guidelines and you can pass it. No, you cannot pass the exam. Please make it in your mind clear today. You cannot pass the part 3 exam till you read all these guidelines by heart as you read for part 2 exam. Although I would say that during the part 3 exam, the reading the guideline will be much easier and little bit, shorter as compared to part 2. Because in part 2, you are going through each and everything from the EMQs and SPA points. But during the part 3, if you go through the main tables, the headings, executive summaries, they are enough, but you have to go through it. Please remember this. And then prioritizing the situation like emergency or elective or routine. You have to prioritize. If you get the 3 women in the labor ward and one of them is having a postpartum hemorrhage, so you will go towards the postpartum hemorrhage and she is the priority. And this is again coming into the patient safety, right? And then prevention and the spread of the diseases, washing hands, scrubbing yourself. These are all the points. Then the duty of control. You should be honest. You should not hide anything to the patient. And duty of control. These are the buzzwords which they want to listen from you, from the patient safety. Then clinical governance, risk management. All these points, they come in patient safety, like doing the drills, skills, teaching, and all these things which are doing in the clinical governance. We are soon trying to do a workshop on the clinical governance and the risk management, because I have seen the people are very deficient in this area as well. So just keep watch on our website. You will have soon a workshop on the clinical governance as well. So these points are also very important. Then comes a communication. Communication can either be with the patient, with the families, or communication may be with your colleagues. Be yourself during the exam. Whatever you do during your clinical things, in your on-calls, this is the same thing. Don't be panic. This is the same thing you are doing. Don't keep the words down to your throat. Just say the words as you are doing in your clinical scenarios. For example, if you want to call your surgical colleagues for the appendix, for anything, call them. So this is the multidisciplinary team. If you want to expedite the thing towards the consultant level, expedite it, right? So referral, calling for help, general practitioner referral, writing a letter to the general practitioner after the discharge to maintain the continuity of the care. These are the buzzwords which they want to listen from your tongue. Then comes the communication with the patient and the families. As you all know, in our daily basis, we are talking to the patient. Please talk to your patient during your clinic hours. I know we are very heavy. We have to work. We have to take lots of the things during our clinic hours. But practice at least one patient in a day when you are in a OBG. Try to apply your knowledge and the clinical guideline only in one patient in one clinic. It will prepare your guideline. For example, if you see epileptic patient, talk to her from epilepsy point of view. What will happen to her? How her management plan will be. how often you would like to see her, how the other colleagues from the neurology will be involved, how the labor will be, how the things will be, what will be the risk to the baby, and how you will continue to consult to her, and also what will happen to the baby afterwards. All these things, the type of the contraception, at least do one guideline in one day in your clinic. In here, clear introduction. You and as well as for the patient. I'm this and I'm here in the clinic for you. May I check your name and age, please? You can develop your own way to introduce. There is no need to follow anyone. Active listening to the patient, what she is telling. Empathy, duty of control, clear information without the medical jargons, signposting when you are giving something bad news, managing the anger, anxiety, disappointment. Make sure the patient is competent, right? For example, if the patient, she is in pain and you are discussing about the tubal ligation, this is not the right time. Maybe she is not competent because of the pain, maybe her age. So all these things you have to go through before you communicate with the patient. And how it will come? It will come with the practice only. Nothing is an alternative to your practice. Nothing is alternative to your day-to-day work. Then comes information gathering. What is an information gathering? You know, this is the history taking. However, in the information gathering, make sure she is the right patient, right information. When you go and the first interact with the patient, always say that I am this and this. I'm Dr. Yasmeen Haseeb. I'm the doctor in the clinic today. May I check your name and age, please? How would you like to be addressed? So this is how you start rapport with her. Appropriate and targeted history taking. For example, if she is a case of abnormal uterine bleeding, so you should target the abnormal uterine bleeding. Just go through the contraception very quickly. Might be the abnormal uterine bleeding is because of contraception. However, you should manipulate your case accordingly. Like, you should not waste your time. Always practice and make your time allocation for the history taking. When we will be doing the cases and we will be doing the case scenarios, there we will practice all these things. Clear communication, logical question, consent of the patient. Even if you want to have the history, may I start asking few questions from you? This is the consent. If you want to ask something about something very personal to her, you have to take her consent. If you don't mind, can I have this information from you? You know, this is very important from your management point of view. May I take this history? Maybe she is having some sexual problems, or maybe she has a multiple sexual partners. So you have to be very gentle, and you should not have any judgmental attitude in the foreign exams. Confidentiality, data protection. Not only that, this is not only during your history taking, but also once you are doing your work in your computers. Don't leave your computers open. This is also comes in the confidentiality and the data protection for the hospital. Examination should be targeted, justified investigations, why you are doing it, interpretation of the results, audit, research, and summarizing capabilities. They will always ask you, can you please give me the summary of your case, right? In the end, the examiner is always asking you, and you should know how the summary is made. Make it every day. All your patients which you see during your exam, make the summaries. Then you will be mastered in making the summaries. Then comes applied clinical knowledge. Here comes your all green top guideline, patient information leaflet, then Faculty of Sexual Reproductive Health guideline for the contraception, GMC safe practice guidelines, NICE guidelines, medications. All of these things you should know by heart. And please make sure you read the patient information leaflet every day. After passing your exam, the first thing you have to, part 2 exam, I'm talking about the part 2 exam, the people preparing for the part 3 exam, they have to prepare their information leaflet every day, revise, and then practice it with even with your family members, even in front of the mirror. And just think, there is a patient in the mirror, and this is you, yourself is a patient, and ask the questions like that. If there is no one, you can practice by yourself. But please keep the door closed, because the people don't know that what you are doing. They may be thinking that you have gone mad, but you have to go mad in order to pass this exam. So you have to talk to yourself. It's okay. You should be in the exam mode. in all aspects. While you are talking, you are walking, you are in the ward, you are in the theater, you are in the exam mode, right? You have to do like this, then you will pass the exam very quickly. So patient information leaflet is very important. Every day, target 5 patient information leaflet. In the beginning, you can target 3, but later on, with the repetition, target 5 patient information leaflet. You have to learn their words, how the words are used. These patient information leaflet, they don't come in one day. They take a lot time, lot of the efforts, and then the appraisal, the critical review, all of these things come, and then they are published at the RCOG website. These are all available at the RCOG website. Even the podcasts are also available. You can listen to the podcast. Some people, they memorize the things when they listen. For example, I am the one, if I listen the things, then I remember it. So this is also a benefit of it. Marking in exam is very important. Marking in the exam, how it is done. It is done in 2 ways. One is OBGYN context, which is task related, standard setting, and information. This is how the RCOG says you have to mark in the exam. And the second one is from the GMC context. So let's see what are they. So OBGYN context, they are asterisk statements are must, especially the patient safety. This is what I told you before. Then referring to the RCOG, patient information leaflet, consent advice, other guidelines is a safe way to go through it. They are all available at the RCOG website to go through and to pass this part, that is the OBGYN part, in your exam. It's easy to pass this part of the exam by going through the guidelines, by going through the patient information leaflet, consent advices. The delegate is expected to mention all these points in all stations, right? So it doesn't mean that you will be asked each and every domain in every station, but there are the domains which are to be expected from you, even if they are not mentioned there, if they are not written there. The patient safety is one of them, right? Then comes a GMC context. Actually, the GMC context, to understand, is a complex thing. It's not actually a global judgment. The GMC is looking at you specifically in 2 areas. These are clinical governance issues and the serious errors and omissions. They will carry 0 marks for that domain. If you will omit the important points in that domain, specifically the patient safety, they will give you a 0 mark in that. This is GMC, what is written in the GMC context. This slide is also, these 2 slides are very important. So I mean to say, you are assessed during your exam in 2 aspects. One is your knowledge, your application, clinical skills, competencies, which is from your OBGYN point of view. And the second part is from the general medical council context. They are assessing you from the clinical governance points. Here is an area where the overseas candidates fail. This is what I have seen. They don't know how to manipulate the clinical governance issues. That's why I have decided to do the workshop on the clinical governance as well. And then the serious errors and omission. You did not check for the allergy. For example, this is a serious error and she may die because of that injection. So these are the things which GMC context is there. Then remember the result. The result is actually, you all know there are 2 types of the assessments. One is a formative assessment and another one is a summative assessment. Summative assessment is actually the final assessment, which means either you pass or you fail. However, in between the 2, there is a borderline. Before, in the older exam point of view, we were giving the marks like 0, 1, 2, 3, 4, and 5. However, now in the new way and the pattern, there are the 3 things only: pass, fail, and in between this is a borderline. Pass is the clear-cut pass, and this is 2. Borderline is 1, where it can help you in getting pass if you do the other stations in a perfect way. And the fail is, of course, fail. And the people usually fail in the patient safety and the clinical governance point of view. So this is how you are marked. This was about the analysis of all the exam itself. How to start, where to start, what you are expected during the exam. Let's see what is an OSCE stuff, what you have to read. This is also an important slide. And here you can just take a screenshot of it This is actually a patient information leaflet, a must read, as I told you. Then part 3, MRCOG, your essential revision guide. You all aware about this book. This is a Liz Joel who has written this book, and this is a very beautiful book which is touching each and every station, that how the different station you will be facing. So you have to take this book and you have to practice each and every station of this book. Very, very important. Then comes the basic practical skills in obstetrics and gynecology. This is actually a book where you will go through the basic obstetrics emergencies and also the basic practical skills. For example, how you do the stitching, how you do the cesarean section, how you handle the breech delivery, how you handle the shoulder dystocia, lot of the things. This is a basic practical skills book by the RCOG itself. OSCE Inside the Track. This is also by the RCOG. So these are all the must-read things. Then I would say that another book, which is an OSCE for the MRCOG Part 2, a self-assessment guide. This is Tony Hollingworth. It's an old book, okay? What I said, this is an old book, but I love to read this book. This is a very beautifully written, although this is from the old style, but you will get a lot of the scenarios and you will get a way how to answer the things. So please go through if you get time. Then comes Justin Clark. This is actually the Get Through MRCOG OSCE Part 2. This is like, you know, the older way. These are old books. So these two books, they are the actually older books. However, these are the upper part which are showing you these books. You are like supposed to read each and everything from here. Very important strategy. Might be there are few people who don't like to read through the strategy, but I tell you, this is a must read. Go through all the modules and their case studies, maybe few case studies and a few questions in your part 3, they come directly from the strategy. Remember it, and you have to go through these case studies, how they are putting it and how they are telling you the answers. Practice them. Download case studies. For example, if you are doing the gynecology, the general thing, you have to download all the case studies and read them. Similarly, the labor ward. The labor ward, you will see a lot of the stuff on the strategy, are beautifully written and a very well done strategy. This is a very good resource by the RCOG itself. So please, you have to go through the resource which is given by the RCOG itself to you. So read through it. This is very, very important strategy and strategy. Then comes the courses. What are the different courses? If you can get time, you can have the course by the RCOG itself. Booking the RCOG course is really very difficult. With the great difficulty and with lot of the suggestions, we convinced RCOG that there should be an online course. And the RCOG is doing the online course as well, where you will also see me there. It's coming in October. The one that you must do is the RCOG course, simply because it is the best. If you can do it face to face, this is the best thing. However, because of some of your problems, you cannot travel, then you can even book it online and you can taste the real thing even in the online exam. And then the Tom McFarlane, you are all aware about Dr. Tom McFarlane. Really, he is a gem in the MRCOG. He usually comes during the ceremonies, and he is an old guy over there, and he is conducting a free tutorial which is twice a week, not only for the part 2 but for the part 3 as well, and he records it and then he puts it on the website. This is a wonderful effort, and we really appreciate Dr. McFarlane. This is the one you can go through that, and he is putting all those things which the college is looking in you. Although he's an old guy, but he is up to date with all the new things which are coming. So this is another very good resource, and any other course which is suitable according to your availability of this course and according to your pocket of course. So these two, and specifically the RCOG one is the must one. If you can get the place over there, as the booking window opens for a while and it closes very quickly because the seats are filled like anything. Let's move on to the stations. What are the stations? What happens in the stations? In the stations, when you will go to the exam in the morning, they will call you. And early morning, there is a meeting with the examiners, and then they are briefed about that what are the cases and which examiner will do what type of the station. The instructions are given to the actors, to the examiners, and everything is planned out and numbering is done. And then comes to the station. There are 14 stations, as you all know. What will happen in the station? You will go and you will hear a buzz. A buzzer will come, and then you will go to your required station. For example, maybe you will start by station number 7. Somebody may start by station number 2. Some may start from station number 1. However, you have to be careful and you have to listen all the information and the instructions which are given to you by the people who are giving you a debriefing in the beginning of the exam. So listen what they are telling you. So when you will go there, what you will see there is a scenario which is pasted outside the cubicle. And inside there, you will see few people are sitting, or you may not see anyone, depending upon the case scenario. So what you will do, you will read the scenario and you will make your mind and write the buzzwords and plan. You will also be given a pencil as well as a small paper over there. They are provided to you. What happens inside the cubicle? After doing all this, you will go inside the cubicle. So please be yourself. This is you. Don't change yourself. Be calm and stay positive. And tell yourself, I am this doctor and I can do it, right? Take a deep breath and approach each station as a new one. For example, you were in previous station where you did not do well and you are thinking it's failed or it's borderline. Forget about it. Forget about it and forget about it. Go with the new one. Don't think about the previous station. Very important trick. You will have the time to read the question inside the room. For example, if you did not get a full time, you were nervous, you were anything, or you were collapsing, or you were dying, you did not have the time to read the question outside, forget about it. There will be a question on the table inside for the candidate. But the candidates are in such a hurry and they are so much stressed, they don't see inside. Many a times I'm telling them, there is a question paper. Doctor, you can read about it. This is in front of you. So don't make the things hurried. Take it easy. This is your labor ward. This is your clinic. This is your OR. Be confident. Believe on yourself. Be yourself, but show you are a competent and safe clinician. Even if your last station was a disaster, remember, OSCE tests your attitude and application of your knowledge. Not only your knowledge. A bad station does not mean that this is your destiny and you will be failed. If you don't know anything, don't bluff. Don't say the wrong things and don't bluff. Here is the part where they can fail you straightforward, right? For example, if you come across to a station where you don't know anything, at least introduce yourself, ask the patient, okay, and try to take the history. At least get borderline in that area rather than failing and rather than keeping quiet. Many a times we see the people who are coming inside and they are quiet. Don't do like this. Try to say something. They are not going to kill you. You will come home back, right? I'm sorry to use these words, but this is the real scenario which happens. So what will you do outside? Outside the station, read carefully. Read carefully. What is this? For example, a patient who is 28 weekers and she has got a high blood pressure with the headache, with epigastric pain, and she has albuminuria 2+. Immediately, your mind will open up in preeclampsia and you will start registering. Okay, so this is my preeclampsia patient. What I will need to do, in the history, I have to ask about headache, visual disturbances, epigastric pain, her output, her fetal movements, her bleeding, blindness, visual loss. These points and these templates should be ready when you are preparing. And that template will open up in your mind. This should open up in your mind. Or, for example, there is a patient who has got in the second stage of the labor and she's not progressing, okay, and her head is down. She's refusing examination. So you are thinking this is a difficult patient. And I have to be very sympathetic, and I have to talk very gently, and I have to give her the options. What are the options? I have to do the examination first of all. I have to console her. I have to do her counseling. I have to examine her. I have to give her the option of instrumental delivery. Okay, and then I have to give her the option of the cesarean section. Okay, but before this, history. History very important. Although history is not indicated in all the cases, but for your safety and for patient safety, I tell you one thing: take a brief history just to know about what is your case. Then immediately you can get some point from the history. History, if it is not required in that case, just give 1 minute to the history and just ask. For example, mimic it. Like if you are going for the PPH room, just ask. In the meanwhile you are doing the resuscitation, immediately you will also just say, I will also ask my midwife about the type of the delivery, what happened during the delivery, and what was her situation. Very quickly, they will give you this information. They are supposed to give you this information. They are supposed to give you the prompts. Then think. You have read. Now you will think. As I told you, I'm thinking my case is this and this and this. And then I will make a plan. I'm standing outside the cubicle. I'm still outside the cubicle. Then, okay, if I will go for the termination of the pregnancy, why? If I will go for cesarean, why? If I will involve the multidisciplinary team, why? If I will go with conservative management, why? I have to justify, right? Question sheets are also there inside the cubicle. Please relax. If you miss something, then the question sheets are also pasted inside the cubicle. Forget about the last station and your performance there. This is all which you are doing outside the cubicle. Now you have entered in the cubicle. What you will see? You will see the examiners, or there may be something for the written, for writing, like the linked task, or you can see some patient sitting over there. Anything you can see. What are the examiners? The examiners are actually the trained clinical examiners, which are usually featured on all the 14 tasks by default. Maybe in some area, if it is a writing task, there may not be a clinical examiner. However, in most of the scenarios, you will see the clinical examiners over there. They're all the faculty members who are very clever in their performance, and they are all trained personnels. So you will also see a trained lay examiner. Who is he or she? This is actually a common person who is an actor, and the college brings them and pays them for being the actor over there. You can see them on either 4 or 5 out of the 14 stations. What they will do, they will assess how you talk and how you treat. Are you sympathetic? Are you worried about them? Are you giving them the proper information? Are they registering the information, what you are giving to them? Or you are just in a hurry and trying to pass the exam? So this is what they are looking in you. So they can be the patient safety as well, and information gathering from the perspective of the patient. And you know, these lay examiners, they are very well trained and given the instructions in the morning. They know their trick. And once you will leave the cubicle, this examiner will ask this examiner, what do you think? How was she? Did she answer all of your questions? Are you satisfied? Did you get the proper information? Did you understand? Was she empathetic? Did she say sorry for anything which was missed? Did she say this? Did she said this? Whatever. And then this examiner is also very important to pass you. So please don't ignore this one. Now, inside the station, what happens? Develop your own way of introduction. Everybody, like I was doing. I'm Dr. Yasmin. I'm the OBGYN doctor in the clinic today. And may I check your name and age, please? How would you like me to address you? Okay, Sally is good. Fine. So, Sally, may I know what are your concerns, or what have brought you here today in the clinic? How may I help you? Like, there are different ways. How the English people talk, how the Arab people, they want to know, how the Saudi board is looking for you. Like, all the exams are almost in the end the same. However, you should develop your own introduction. There is no need to follow anybody. Whatever you feel comfortable, you should do. But this introduction should be concise, effective, clear, focused. These are the points which it should cover. And if you are not sure you are doing these things, then you can ask your colleagues, you can ask your senior doctors, you can ask in the courses, am I right? Should I do this? Write 2, 3 introduction and just record them and listen to them by yourself. How you feel as a patient. Listen to your patient carefully and actively. Don't interrupt her. If you want to interrupt, and sometimes the patient, they're talking here and there and they are not to the point, then you may bring her very gently back towards the normal, back to the point. Eye contact, look at her, not at your notes. There are the people in the exam who just ask and write, ask and write. There is no need to write anything. Just ask. You can register. You can register for a patient. What is she? What is her pulse? What is she feeling? How is the bleeding? How is the pain? Where is the pain? You have to talk to her, listen to her, show your concern. Yes. Okay. Yes. Anything else? Yeah. Like all these words, nodding, right. Okay. Gently. These are all the words. If you says, oh, I suffered a lot in my last delivery. It was really very painful. There was a hematoma. They drained it. And, I suffered a lot. I have to undergo a lot of the things. This happened, that happened. You will say, oh, really? I'm really sorry to hear about. And you suffered a lot according to the situation. I'm really very sorry about it. How are you feeling now? How are the things now? Give her time. Show interest in her story. Don't be in a hurry to finish your station. Even if you don't finish your station, you are answering her concerns. You are touching the patient's safety. You are doing very well the communication. You can pass the exam. Ask the open-ended question. Though closed-ended questions are also helpful. You should know what are the closed-ended, what are the open-ended questions. And then in between, ask her, am I clear so far? Are you with me? Am I with you? Are you satisfied? What else you are interested to ask? Is there any other agenda which you want to discuss it today? Might be she has come for something else, right? So at the end of the history, you have to ask, what are the other things you are looking for from today's consultation? How can I help you? Is there anything else which would you like to discuss today? In each history, you should ask this question. Sometimes she gives you the information which she was hiding, and she was instructed, don't tell the candidate until unless she specifically asks you for anything else you want to discuss. They want to know whether you are really going in depth with the patient or not. There is 1 or 2 stations like that in the exam. Sometimes the patient guides you. She gives you the hint. There are so many good patients as well. She guides you. She gives the hint. Try to pick their clues. Right? For example, she's telling you, oh, doctor, there is a lot of the vaginal discharge after the cesarean. And she is coming with abdominal pain. You are concentrating only on the abdominal pain. Might be there is a swab inside the vagina after the delivery. So take those hints. Now, the important tips during your preparation, I would say that for each case, history taking pro forma, very important, as I said, for preeclampsia, antepartum hemorrhage, for infertility, for gynae cases, for labor ward, what are the different types of the performas? Introduction and then the performa. Introduction, how you will introduce yourself in each station, and then history taking performa, then study buddy. Always helps. You should have a very sincere study buddy. This is very important. Catch hold of anybody who will listen to your tone and attitude. It can be your husband, it can be your wife, it can be anyone in the family, right? Or it can be your friends. Or if there is no one, you are free, you have the time, open up your mobile phone, record yourself, the scenario, listen to yourself along with the timer. That did I finish it? Did I test it? Or did I go through all the areas which were asked to me? And listen it to yourself. Give yourself the marks. Don't waste your time. Because in the OBGYN, we have very limited time. We have to do a lot of the things, but we have to go through all these things because we are different people. Don't waste your time. Use the mobile. Try practicing the diagrams. These are very important. For example, if you are telling somebody that there is a tubal blockage, you can just draw a small diagram and just say, okay, this is your uterus, which keeps the baby and brings the periods. And these are the tubes through which the eggs comes into the tube, and then the sperm meets, and here is the fertilization and the baby forms. You have to learn the words, baby forms here. And in case of the cause of not getting pregnant seems most likely this is the tubes, and it seems these are blocked. So how we will get through them? We have to do some further investigations, and these further investigations need histosalpingogram, or you want to do the laparoscopy, whatever is according to the situation, you can take the practicing diagram. Similarly, if you are teaching a PPH at the teaching station, and you are teaching the PPH, and you want to teach them the B-lead suture, you can do that. Or if, for example, you are teaching how to do the episiotomy, you can draw the diagram and you can tell them where the episiotomy is given. Like, practicing the diagram is also very important. I'm giving you the very deep parts which are required from you. Then use patient-friendly language. How it will come? This will come from your patient information leaflets. Right? Very important, the last part, dress up very nicely, but don't dress up like you are going to a wedding. No, you have to dress up like a professional, like a doctor. Keep calm and pleasant. Your face should be pleasant, smiling. Although from inside you are dying, but you have to put a smile on your face. You have to show you are very calm. And please avoid taking any medications which are giving you, you are sedative or anything, or the beta blockers. The people are using the beta blockers because of the tachycardia. Remember, this is an exam. If you will fail, no problem. You can attempt it second time, but be in yourself. Avoid crossing the fingers. Always keep your hands open. And you should have an eye contact with examiner, with patient, with anybody. I hope so. These are the small tips which I would say that are important. You can do all of them if you concentrate. So here are the upcoming courses by the RoyalDocline, which is about the clinical governance, in-depth CTG courses, MRCOG Part 2 full course, and how to read a guideline, recall courses, MRCOG Part 3 OSCE. We will form a WhatsApp group and a Telegram group where you can practice about it. And we will be starting our course from August to November. And there will be the weekly tasks and also the discussions. We will be arranging an MRCOG OSCE recalls, what exactly the RCOG wants from the overseas candidate. And you can follow us on our social handles, and you can keep watch on our RoyalDocline website, and you can visit us. You can give us the feedback and what else should be included. What are the difficulties you are facing? We can do that. So now, Isa, there is a time to do the Q&A, and let's address your questions and queries. So I'm here to
Okay.
answer, please.
Okay, first of all, thank you so much, Dr. Yasmin. That was a very informative and in-depth session that you have done. I'm going to now read some of the questions. The first
Yeah.
question is, will you do webinars on part 1 and part 2 for some of us who haven't attempted the previous parts? I guess there are some fresh grads here too.
Yeah, actually, we are planning to do that, and we hope so soon you will get it. Being a very, busy, it's really difficult thing. However, I'm trying to do it, and soon they will get the information about it.
Okay, Miss
Just
Liza
keep
is
watch
asking.
on our website, which is a Royal Doc, because Isa and all my dear participants today, I am trying to do these courses since long time. This is my wish and will to help you, all my candidates, specifically the overseas candidates, which I am having. I have experienced that. People are struggling hard to pass this exam, and now I have decided to do something for them.
Okay, great. Another question is, what kind of clinical scenarios can I expect to encounter in MRCOG Part 3 exam? Can you give one or two examples from your own experience, please?
Yeah, as I told you, there is a syllabus, and in each part you will get one or two scenarios. For example, let's discuss about the teaching. One time we put a question regarding, there was an FY1. This is a foundation year. Actually, the training over there is totally different. There are the foundation years, and then ST1, ST2, ST3, ST5. Actually, you are assessed at ST5 level. MRCOG candidate is at ST5 level. And in the teaching station, there was one scenario, you are having an FY2 in the station, and she has just joined your hospital, and she is very keen to learn about the episiotomy. So how will you demonstrate her? This is the way, for example. So there was a paper and there was a pencil, and also the candidate was sitting over here. So this type of the things you can get it. Over here, they were assessing you in the patient safety. They were assessing you in the applied clinical knowledge, communication with the colleagues. So these were three domains which they were assessing you. So here you were supposed to read the question very properly. You have to make your mind. And first of all, you have to remember that you have to build the rapport with them. And how you will build the rapport. Hi, this is Dr. Yasmeen, and I'm in I'm the ST5 in our hospital. Hello, how are you? How are you doing? May I know your good name, please? She will say, my name is Lisa, for example. Okay, Lisa, how are you doing? Congratulations, you have joined our department. How the things are going on? Are you doing well? So what would you like me to do today? Although the question has been asked, but you are again going to ask her, what is her concern today, right? So she will tell you that, or he will tell you, oh, doctor, I have joined and I want to learn about the episiotomy. Okay, no problem. So, Lisa, would you please let me know that what do you know about, the muscles and the anatomy of the perineum? Just first of all, you have to access how much knowledge she needs. Each station is different, whatever knowledge she has got. Then after this, you will start giving the information. You will give the information, you will take the information. Or might be sometimes in the teaching station, for example, there is a doctor like that, and she is here for learning the episiotomy, for example. But in the underlying, the agenda is something different, and the college is trying to access you on that area. And this is the training difficulty. For example, if you will not ask and you will not build rapport, he or she will not open up with you. So you will just ask one thing. Okay, Lisa, how are you doing today? How are the things today? How the training is going on? Are you okay? Are you coping up? How the things are at home? Everything is good. And anything, any difficulty in your training, anything. So would you like me to help in that? I'm your friend. I'm here to help you out like this. So this is one scenario. Second scenario can be, for example, the cesarean section rate is very high in your department, and what are the different types of the measures which you can take to reduce the cesarean section? This can be a structured viva. For example, the examiner will be sitting over there. The question is there. Now, you will take few seconds, and then you will introduce yourself. I'm Dr. Yasmeen. I'm here for the structured viva today. So my question today is that cesarean section rate is very high, and what are the measures to be taken to reduce the cesarean section rate? So for me, first of all, I have to go through the causes, that what are the causes of the increased cesarean section rate. I have to call a meeting with the help of my clinical, my head of the department or whatever is there. And with my colleagues, I will send an email, and then we can have a meeting, and then we can see that what are the causes, why the cesarean section rate is higher. And then I will also make an audit for it. And these are the words which they want to listen from you. Then I would say that I will collect the data, and I will see that what are the indications for the cesarean section rate, and how the consultants are, whether the consultants are involved in the decision making or not, like all these things. And then the measures which you will take. So this is one audit. And then there will be another station where they can put the patient information leaflet, and they can ask you to write a critical appraisal of this patient information leaflet, or they can put some, in our exam, they put this maternal mortality report, embrace report, and they can also, there can be a patient over there, patient related. For example, the patient has come with the Down's syndrome report, and she's here for the counseling. Or there is an infertility station, for example, the male is taking a lot of the steroids, and the sperm count is less. So here, the trick will be only in the history. And then there can be the station where there is a bowel injury after the laparoscopy for the endometriosis treatment. So these are the things. The stations are different in each point of view. For example, medical disorders, you can get peripartum cardiomyopathy, for example. Clinical governance, you can get all this teaching, as I told you. And in gynae cases, you can get the question about the management of the fibroid. Contraception, you can get, and sexually transmitted infections can also be there in the contraception module. Like the stations are different, and you can get the different scenarios over here. It depends upon. We will be discussing it, inshallah, in our courses, upcoming courses.
All right, the next question is from Lubna Islam, and she's asking, are there any similarities between MRCOG with our FCPS exam of Pakistan?
Actually, I tell you, MRCOG, MRCPI, these are really, really something which are globally, internationally recognized exams. The similarities, yes, there are the similarities that they are all the OSCEs are almost the same. But in the European exams, they are looking more towards the clinical governance point of view and duty of candor. These are the things. And errors, omissions, these points are more emphasized in those exams, although the OSCE exams are almost the same. That's why this webinar was not only for the MRCOG UK candidates, but for everybody who is preparing for the exams, whether they are for FCPS, MCPS, anyone. Uh, Actually, the backbone is the same.
All right. There are a couple of questions about any paid courses which are worth it apart from the free ones. Do you recommend specific resources or paid courses that one can take?
Yeah, actually, you would say on the Facebook, on the different areas, that anyone just did the part one and they're doing the part one courses, passed the part two and they're doing the part two courses. In the true, as a duty of the condor, I would say that RCOG's course itself is a big, big, good source. And you can get this course through the strategy as well, the strategy itself. And also try to take the courses by the RCOG itself, which is the RCOG its own material. Although the people are doing a lot of the courses, but they don't know what exactly teaching is. Teaching is an art. When I did my medical education certification from the Dundee, although I was in the teaching for a long time, I was totally and entirely a changed person. How they're talking, what the teaching is exactly. So you should be very smart enough in choosing the course rather than just wasting your money as well as your time. However, you can join our course. This is not mandatory, but you can join and you can have a taste. What is the difference between our course and the other courses? You will see the difference.
Okay, great. Miss Aisha is asking that if she can prepare her exams along with her practice, and she's specifically asking that how many days or weeks you think one should reserve solely for revisions only.
Aisha, she's Aisha.
Yes, she's Aisha.
Okay, Aisha, this question is very important, and most of the candidates they are asking me. I would say that every candidate is different. Every candidate situation is different. So it depends upon you. But if you want me to tell you, actually, 6 months is required for part two, just to prepare and to go through all the guidelines. But it depends upon you, how much you digest, how much you retain, and what is your way of teaching. A lot of the things that matter in this regard. But I would say that usually the 6 month is enough for the part two, and 3 months are enough for the part three as a rough.
Okay. So the next question is very interesting. Miss Madeline is asking, what are the common mistakes that you have observed as an examiner, which should be avoided during MRCOG Part 3 exam?
Very nice question. And this is actually the extract of today's webinar. As I told you, for being very, busy, I was always trying to do the courses. However, RoyalDocline team and my family, they supported me to arrange these things now. Uh, Actually, this is the point which I want to highlight. The most important mistakes are, number one, your not understanding the exam itself. Number one, as I told you, understand the exams. How you will understand the exam? You will not understand the exam by talking to someone who is senior to you. No, you will understand the exam by going through the website of the exam which you are preparing. For example, if you're preparing RCOG, go through that website. If you're preparing Saudi board, go through that website. If you're preparing MRCPI, go through website. and try to see what they are written over there, and try to formulate and try to understand what they're trying to see in you, the format, the syllabus, the modules, and everything, the stations. First of all, try to understand that one. So I have seen that people don't understand actually what the exam is, and they are thinking, okay, it's OSCE, it will be very easy to pass. No, OSCE is not easy to pass. This is judging everything from your communication, from your clinical skills, from your practical skills, everything in the real scenarios. What you do, this is one part, that's the selection of the material. Number two, selection of the courses. Try to do the courses which are really by someone who himself or herself has got experience as a teacher, as a faculty, as well as someone who knows how to teach and who herself or himself is involved in these exams. Number three, the college courses itself. For example, if you are doing by the Saudi board is also arranging the courses itself. MRCPI is arranging the courses itself. RCOG is arranging online. So these are very important, their resources itself. Then you have to read the material in depth. You have to do the practice. And what else I have seen is the people, they become panic. They don't rely upon themselves. This is also very important. And after you do the proper things, you should be confident that you can do it. This is very important. And another important thing, they do not prepare in a proper way. As I told you, the tips in the end, that is, you have to make the pro formas for each and every module over there. That, okay, this is infertility module, what I will need to do. This is a contraception module, what I need to do. You know, there are the different things you have to do in different stations. So that is the point where you need to know. These are usually the mistakes. And one more important thing, which I always highlight to my residents, to my doctors who are working with me, and some of them are also here. Uh, they will be laughing right now. I'm always catching them on the clinical governance point. You know, I'm always telling them, okay, tell me, what will you do? Did you write she's competent? Did you write the duty of candor? Did you do the incident reporting? This is just a day-to-day practice. Put these words into day-to-day practice. Clinical governance is the point, and the research is the point where most of the people they fail. So these are the important points: your preparation, selection of material, not understanding the exam, not doing the proper courses, and not having the study buddy, and not going through the clinical governance. These are the points where usually the people fail.
Okay, Miss Mavish Raza is asking if MRCOG has any trick questions or any common scenarios which are repeated time and time again and should be focused especially on.
Yeah, they are actually, it's not 100%. You know, this is actually a guess. The people are uh, in a habit to take the guess from their MBBS actually. So the guess, and usually the questions which are repeated, you know, they want to do the audits, they want to do the critical appraisal, and also the teaching and Down's syndrome. They love to do it. And angry husband, ruptured uterus, and the angry husband. And these are the scenarios which are usually the one they are asking during their exams, because they know the people don't know this.
Okay, so the next question is how important is experiences in managing complex obstetric and gynecological cases for your success in MRCOG Part 3?
Uh, Doctor, I would say that although the experience is very important, but along with the experience, you have to learn the tips and tricks, how you will present. Experience, you know, this is a clinical experience. For example, if someone is managing the bowel injury after the laparoscopy, right? But if you cannot recognize during the exam, there is no advantage of having this experience. If you are not saying the duty as a duty of candor, I will tell the patient that, or I will debrief the patient using the word debrief, using the word duty of candor to the patient. These things, they matter. Although the experience plays a part, but to a little extent, because this exam is actually at ST5 level in the MRCOG. It is at the ST5 level. From the ST5, they jump into the special training later on. So experience counts, but before the experience, they want to assess the other things in you. So don't rely upon only the experience. You have to learn the other things as well.
Okay, so this question has been repeated a lot, and a lot of our participants are asking the key differences in format between the MRCOG part 1 and 2 and 3.
The key difference is in
Between the three parts of MRCOG, part 1 and part 2 and part 3, what are the differences, the key ones that one has to focus on?
the key differences.
Yeah.
Actually, I tell you, uh, every exam has got its own parts, part 1, 2, and 3. Let's talk about as an example, because I'm more involved in MRCOG and MRCPI exam. So let's talk about the MRCOG, for example. MRCOG exam has got the three parts, part 1, 2, and 3. In part 1, they are looking at you the basic sciences, because they are training the doctors starting from the scratch. That is how much you know about, for example, the anatomy of the female genital tract, but not only the genital tract, some part of the abdominal area is also, some part of the perineum, some part of the upper thigh, they are including in that, because, for example, they are doing the nerve block, pudendal block. So they are asking you all those areas. And what are the complications? What can happen? So this is the anatomy point of view. Similarly, if you go to, for example, the physiology, okay, how the uterus works, what is a menstruation, menstrual cycle, what are the hormones, how they are affected, because these hormones are not only involved in the menstruation, they are involved in your abnormal uterine bleeding, they're involved in the infertility, they are involved in contraception, for example. So they want to check that knowledge. Similarly, they want you to do the biostatistics. Biostatistics is involved in lot of the research, how the different types of the researches are done, how the 2 by 2 table is used, what are the number needed to treat, and what are the risk ratios, what are the different types of the studies, what is a case control study, what are the case series, like that, what is a descriptive study, for example. So they want to know your foundation, and they will assess you in that. This is part 1. And after assessing you in part 1, then they take you in the training. And actually, the part 1 is done at FY1 or FY2 level. After passing this exam, you go to the ST1 level. And in the ST1 level, you are supposed to go through the different guidelines. And these guidelines are about the management. For example, if you go through the green top guideline, you will see a lot of the guidelines over there. For example, nausea, vomiting of the pregnancy, intrauterine growth restriction, and epilepsy, third degree perineal tear, uh, obesity, lot of the guidelines. And then you will have the NICE guideline regarding the different, for example, the labor guideline. You will have the British Society guideline for the blood transfusions, hematological disorders, or you can have Faculty of Sexual and Reproductive Health guideline for the contraception. So in the part 2, in the part 1, they just assessed you in the basic core knowledge. In the basic core knowledge, they are assessing you. Okay, what will happen if the pudendal nerve is damaged? Okay, what will happen if the inferior rectal artery is damaged? What will happen? Where is the blood supply of the right side of the ovary? Like that. They want to know, do you know the fundamentals? Now, in the part 2, they want to know how much have you learned from your clinical experience, and do you know how to apply the guidelines, and what will be the best thing you will choose for that patient. They are doing it by doing the single best answers, as well as doing it by going through the extended matching question. And extended matching question comprehensively access you in your knowledge. You cannot attempt the EMQs if you don't have a solid core knowledge. The people who have appeared in the part 2, they already know what exactly is I mean. So you pass the part 2. Now comes the part 3. Part 3 is the one which is accessing you not only in your clinical knowledge, but your clinical skills, your attitude, and your communication. Now the things are different. That was only the knowledge and the proper selection of treatment in the part 2. Part 1, basic knowledge. Part 2, the basic things and the knowledge, the application of the knowledge. And in part 3, not only the knowledge, the practical way of applying this knowledge, communication, your practical skills, your operative skills, your communication skills with the patient, with the colleagues, and your attitude. These are the things which are assessed in part 3.
Okay, so one last question I'm going to take. Okay, so Miss Martina is asking how crucial are to master communication and patient management skills as a doctor before performing well on MRCOG Part 3 exam. So she's asking, is there any benefit to master, communication and patient management skills? Does that help with your prep in MRCOG Part 3 exam?
Of course, 100%. Because communication with your patients, with your colleagues, is one of the domain. Rather, there are two domains now: communication with the patient and family, and communication with the colleagues. So, without communication skills, you cannot pass this exam. If you don't talk, if you don't know how to talk, and if you don't know what are the words you need to use, then you cannot pass this exam. 100%. You have to go through it. And the one thing she was asking, how you can polish them, how you can get it. You can do it by daily, day-to-day work. Talk with your friends. Talk with your study buddy. Talk with your patient. As I said, every clinic practice one case scenario. For example, you get the toxoplasmosis. You are sitting in your clinic. A patient comes with a toxoplasmosis report. Okay, do it with the patient. And sometimes it is difficult to do it with the patient. Okay, fine, you are busy. So write it down in your schedule and do this toxoplasmosis with your colleague or a study buddy on that day. Or if nobody is there, you have to do it by yourself in front of the mirror. Mirror is your patient. Or if not, you can do it by recording itself on the phone. Nowadays, we all have the cell phones and we can all record and we can all listen. See how you are speaking when you are communicating to the patient. Listen your voice record, and by putting a stopwatch in an side, and see how you talk to the patient. Then listen yourself and think that you are a patient. Now your doctor is talking to you. You will see, you will laugh. I tell you, you will laugh when you will listen yourself, and you will yourself come to know what are my mistakes.
Okay, so practice is very important. Okay, Dr. Yasmin, I'm sorry, there is one last question and it
Please,
is
I want
specifically
to know
in
questions.
Okay, it is
Please.
specifically in Pakistani context. So a student was asking that they are not taught biostatistics during their MBBS course. Do you think that MRCOG Part 1 material is enough for the biostatistics prep, or they should, separately prepare for biostatistics concepts as well?
Actually, it depends upon you. They want to see whether you know the biostatistics or no. Although the course material which is given in that book, which is recommended by the RCOG, however, it is up to you that whether you can get it or not. You can consult some other books as well. This depends upon you. You can see the past papers, how they are putting the past papers, how they are asking you to calculate the odd ratio, how they are asking you to calculate the number needed to treat. So if you can do all of this, it's okay. If not, then you have to take the help of the other course material. So this depends upon you.
Okay, so there is another small question, and
Please.
they're asking, are paid courses worth it to prepare for the exam?
Of course, they are, at least in your busy schedules. You can do that. But please remember, select the courses very wisely.
Okay, great. Okay, Dr. Yasmin, I think we are good. There
Mhm.
are a couple of compliments. The participants are thanking you for
Thank you so
addressing
much.
important topics. And the feedback is that the webinar was incredibly helpful. And there's also requests for doing more sessions like this. Like a lot of people are saying, because you make it seem very easy to understand.
My player. I really appreciate everybody who has joined us today in our webinar. And my special thanks to Dr. Iza, who is with us and taking the questions and making the things easy. Communication, Iza, it was not possible without you. Special thanks to you. Special thanks to my RoyalDocline team who made it possible, and everybody, Waleed, Shahdar, everyone who put their effort. And on the top of it all, our near and dear valued participant, you kept on engaging in the webinar today. I'm so happy. And I think I got my objective today to conduct this webinar. I was surprised, 160 participants were there today in the webinar, and which means that the people are really want to know that what exactly is needed from them during the exams. And this is my aim, that I actually have two aims. One is a safe motherhood initiative, and another one to guide the people in the right track, specifically the overseas candidates, because they are struggling hard with their families. They are spending the money. They are having, sleepless nights, and the family is suffering as well. Kids are suffering as well with their exams. This is my main. And I would say that with all my thanks, that never lose hope. Keep going, and you can do it one day, and you will be there in the ceremony one day by getting your MRCOG in your hand, and you will then forget everything. And soon it is coming. A good time is coming. I would say that. And I wish you all the success in every aspect of your life. And keep watch on our website, as we will be sharing in the share here. Kindly share our website link so that the people can register and keep watch on our newsletters, as well as they can see that what are our upcoming courses, and we will meet you soon again.
Okay, thank you so much, Dr. Yasmin. Best of luck to all the participants who are going to appear this cycle. And again, if you have any questions, you need any help or guidance about anything, please don't hesitate to contact us. You can message us or email us, or just, hit us up on our Facebook page. We would love to see you again in our next webinar. Thank you so much again, Dr. Yasmin, for your valuable time and guidance.
Thank you, everybody, once again, and goodbye.
Goodbye.